Good afternoon, everybody. Welcome to our CBAS updates for this lovely day in October, October 7th. We're so glad you could join us today, and we're looking forward to sharing some information with you. We have probably about, I think around over 300 people or so definitely on our call today. So definitely lots of people joining us, and hope that we'll be able to provide you with the information that you're looking for. We will. My name is Jill Sparrow. I am the CBAS Bureau Chief of the Field Operations Team, and I think most of you know me by now. Today, also joining me will be Denise Peach, our former CBAS Branch Chief. And we also have a guest presenter with us today, Dr. Thomas Bu, who is a medical officer with the Department of Public Health. And I will introduce him in full in just a short time. Also behind the scenes, Lynn Benjamin, who's going to be advancing the slides for us today. So Lynn, can you go to the next slide, please? Okay. So just again, we usually start these presentations, these webinars, a little welcome and housekeeping. Again, we're so glad you could join us today. Thank you for being here. As always, we welcome your questions. Look forward to taking those. We'll be using the question and answer box. So if you have a question, please submit those via the questions box, and we will be monitoring those throughout the duration of the webinar today. Again, the webinar is being recorded, and we will be posting it on the CDA website as soon as possible. And as always, we encourage you, if you have staff or others that were not able to join us today on the call and would like to listen in, again, please encourage them to listen to the webinar once we have it posted to the website. All right, next slide. So we have lots of information to cover today. At the top of the hour today, we're going to be, Dr. Bu is joining us, and he'll be talking about booster shots and answering some questions. We have been receiving some questions from providers on booster shots, and so we had sent them to Dr. Bu ahead of this presentation today. So hopefully he will be able to, hopefully I know he will be able to answer your questions for you. We'll also have some program updates that we're going to be covering, including the MSSR reporting, a little bit about the CDA move, on-site surveys, etc. And then also talking a little bit about center utilization data and public health orders. And I'm going to start with Lynn right now. I think what I'm looking at is we may have a different slide deck than what I thought. And I'm wondering if you might pause your screen sharing and pull up the final deck that we have, if you don't mind. So we'll just pause right there, everybody. While Lynn is pulling up the provider webinar, the final draft, I'm going to introduce Dr. Bu, and who's joining us. Dr. Bu is, like I said, he's a medical officer with in the immunization branch with the Department of Public Health. And also, I guess, currently a family doctor with Northern Inyo Hospital Rural Health Clinic in Bishop, California. So he definitely gets to enjoy the lovely scenery up there in the higher elevations. And he's also co-medical director of the Hospice of Owens Valley in Bishop, California as well. So, and so again, we're hoping, we know Dr. Bu will be able to answer some questions today about boosters. We know with many of our providers, you're working with your participants, and you've been working with them to assist and encourage them to take advantage of the vaccinations that are available. And also now that the shots are available, to assist and encourage them to get those as well. Let me see here, one moment. And I will, Lynn, I'm gonna send that slide deck over to you right now so you have it. Okay. All right. And Lynn, while you're trying to bring that up, I also take one more attempt to see if I can share my screen to see if we can pull that up too. I just want to make sure we're working from the most current deck today. All right. We had been, Torley had been having some issues with my ability to share my screen today. So that's why we're having Lynn, having somebody else.
Jill, I'm searching for the slide deck in our T drive, and I pulled up what I thought was the most recent.
Okay. If you're in that file, does it say final?
That's what I'm searching for.
Okay.
I found it.
Okay, thanks, Lynn.
Okay, so we'll try again.
Okay, let me stop sharing, and so you can do that. All right. After a whole, well, at least a year and a half of doing these webinar presentations, you know, it's we're getting quite used to the occasional hiccup every once in a while. So, and in terms of hiccups, this one's pretty minor. So Lynn's gonna pull this up pretty soon and we'll get going. Thankfully, we've built in some time here today too. There we go.
This is just so. I am going to try one more option. I am so sorry.
That's okay. We'll have let's see if Jennifer too. I know Jennifer's on the line too, and she can be the backup if it turns out you can't pull it up. We'll have Jen do it as well. All right. All right. And Jen, I just sent you the slide deck too.
Okay.
Thank you. Now it'll just be a competition. We can share first, Jen or Lynn. Dr. Boo, would you like to go ahead and proceed with your slides? I know you have a copy of them. Feel free if you want to start.
Sure. Okay.
Can...
Yeah. Thanks, Jill, and hello, everyone. And probably the slides will catch up with us as we go here in a moment. But yeah, I'm Tom Boo, and I was asked to speak about booster doses for COVID-19. It's obviously kind of a hot topic. And some people have found the guidance on the boosters somewhat confusing and unclear, and so hope to try to provide some clarity there, and I'm happy to take questions at any point. I guess I'll wait for the slides to get to the right point of it.
Yeah, we can see those now, those
Yeah,
limbs.
I think it's slide 7 is the first slide that yeah.
Yeah. Oh, no, you had it, Lynn.
Almost there.
Yeah, just hit slideshow. And then click slideshow. And then great, yep, from current slide. There we go. Perfect. Dr. Booth, take it away.
Okay, so next slide, please, Lynn. Thanks. Okay, so recently, a couple of weeks ago, the FDA and CDC did authorize and recommend, respectively, booster doses, specifically of the Pfizer BioNTech COVID-19 vaccine to certain groups of people, as long as it's been at least 6 months since they received their second dose. And they've kind of broken it up into a couple of categories. First, of people who there's a real recommendation. The language that's being used is people who should receive. I don't know if you can advance the slide a couple of slides. I think we went backwards there for a second. Yeah, that's it. So people who should receive a booster, the evidence is strongest for people age 65 and older, and real concern about people who are in long-term care, nursing homes and whatnot. There is evidence that such people are more vulnerable to COVID-19 infection, and including severe disease. But then importantly, people who are less than 65 but 50 or over with underlying medical conditions, or who are at increased risks of social inequities. And experts who were involved in making the recommendations were careful to point out that they mean to include people of racial and ethnic minorities who have been disproportionately affected by the pandemic. And there's different ways to sort of look at that and describe that, and it can be a little bit subjective, but we're basically talking about people who live in circumstances of disadvantage, poverty, maybe crowded living conditions, working conditions that make it harder for them to stay safe. And then there's a much larger group of people who may consider receiving a booster, people who are eligible, but for whom it's considered optional, ideally something that a person might talk through with their healthcare provider. And this includes younger people, 18 through 49, with underlying medical conditions. And I have a slide on, with a list of the underlying medical conditions, but it's quite a long list and quite inclusive. And, honestly, the majority of Californians, between these different criteria, are eligible for booster doses. And then the other category is people 18 through 64 who may not have medical conditions, but who are at increased risk of exposure to COVID-19 due to their occupation or an institutional setting. And this was kind of a controversial one. The advisory committee for CDC was quite divided, on making recommendations for this one. In fact, this is the one where where the advisory committee did not vote to recommend boosters for people based on occupational settings, but the director of CDC, Rachel Walensky, took advantage of her authority to go ahead and make the recommendation in spite of the lack of support from the committee. Next slide, please. So yeah, long list of medical conditions that are known to increase risk of more severe COVID-19. And I don't think I should read the list to you, but could point out a few. You know, there's some obvious things. I mean, cancer, diabetes, heart conditions. I think we all know about that. The immunocompromised are on this list, but in fact, you know, there's the third doses or additional doses for people with immune compromised were authorized and strongly recommended a month earlier in early August, and aren't necessarily a part of the booster recommendations per se. Those folks should get third doses. But I want to point out overweight and obesity, pregnancy, smoking, current and former. So there's a lot of substance use disorders. There are a lot of indications, a lot of qualifying conditions for booster doses. Next slide, please. So in terms of occupations with increased risk of exposure, CDC has provided us with information about who they consider to be at risk, who the evidence shows to be at risk, and that includes frontline healthcare staff and first responders, including firefighters, police, and people who work in congregate care settings, educational staff, teachers, and other school staff, as well as daycare workers. Food and agriculture workers have been hit hard by the pandemic in many parts of the country. Manufacturing workers, corrections workers, so people who work in jails and prisons, postal service workers, which I wasn't necessarily aware of, public transit workers, and grocery store workers. And again, there's a link to the source website at CDC. Next slide, please. Okay, so Jill Sparrow was kind enough to provide me with some questions that I think may have come from some of you, questions that may be on people's minds, and so I've put them on slides. And some of these are really very commonly asked questions these days. And the first one is it okay to mix and match since only Pfizer has been approved as a booster at this time? So honestly, we don't really know. It's not authorized by FDA or CDC at this time. We are waiting anxiously for more data from studies that are being done in different parts of the world. The UK, notably, doing a lot of work with what's called heterologous dosing or regimens, mixing and matching, using an adenovirus vector vaccine, such as AstraZeneca for first dose and mRNA for a second dose, that kind of thing, mixing, Moderna and Pfizer in various combinations. I will note that the FDA advisory committee, which is called VRBPAC, which makes recommendations on vaccines to the FDA commissioner. VRBPAC is scheduled now to meet next week on the 14th and 15th to consider both Moderna and Johnson & Johnson, also known as Janssen, vaccine boosters, but also they're going to look at available data on just this question, mixing and matching. And so we may have more information, more guidance very soon. But right now, I don't have a lot to offer there, unfortunately. Next question, will immunocompromised people who get their third dose still need a booster? If so, how long do they wait for a booster? So currently, it's not recommended. We just don't, it hasn't been long enough. We don't know how immunocompromised folks are responding to the third dose. people are studying that, tracking that, and there will be more data to answer this in time. It would make sense that it might be closer to being recommended 6 months after their third dose. But again, stay tuned. And are there any additional risks associated with the booster shot? Some people experience discomforting side effects and are reluctant to get another shot. Yeah, very important question. And again, the data is still pretty limited, mostly from Israel, because Israel was the first country to start doing booster shots. I think in midsummer this year, so just a few months ago, and they have not identified any major safety concerns, with third booster shots of, and again, Israel has relied very heavily on Pfizer on the shot that's approved for boosters in this country. And the frequency of side effects, what are called reactogenic side effects, like, just feeling lousy for a day or two, flu-like symptoms, sore arm, etc. The type and frequency seems pretty similar between what people experience with their second dose and what they experience with a third or booster dose. But so far, no evidence of major safety issues. Next slide, please. Can you get the flu shot at the same time as the COVID-19 shot? Yes, that's currently recommended. It's allowable, and it's happening in many areas. Next question: when might Moderna and J&J vaccine booster shots be approved? So again, touched on this already, but next week, the 14th and 15th, I think the 14th, the FDA advisory committee is going to be considering the Moderna data, and the next day, the 15th, they'll be talking about J&J, and it can happen quite quickly after that. After they make their recommendations to the commissioner, probably the FDA commissioner will make decisions same day or within a very short time frame. And the CDC advisory committee, the Advisory Committee on Immunization Practices, which serves an analogous role to the VRBPAC committee for the FDA, and basically making recommendations, to the director of CDC. They haven't scheduled a follow-up meeting yet, but typically throughout this pandemic, we would expect them to schedule a meeting very shortly after the FDA makes a decision. And once CDC makes recommendations, then it's actionable. We have the additional step in California and the Western states now of the Western States Regional Safety Advisory Work Group, which will independently consider the available data and the recommendations and probably endorse, but they have the mandate, the charter to modify if appropriate for our state. Next question: if someone in the recommended categories for the Pfizer booster has had a known symptomatic case of COVID and then gotten vaccinated, would they still need the booster? That's still recommended. Another common scenario, a twist on that, is people who got infected, had COVID, perhaps before vaccines were available. Should they get vaccinated on top of it? It's an area of very active discussion, at federal and state public health levels. But it is currently recommended. Many millions of infected persons have received a full series, and there are minimal data and no recommendations for boosters in this scenario. It just hasn't been studied. We don't have the so we do believe that that we do know that people who have been infected and then get at least one vaccine dose on top of it have a very good, a very robust immune response. Whether those people really need that second dose of an mRNA vaccine or a booster dose, we just don't have enough information yet. Next slide, please. What level of protection was found to be conferred by the Pfizer booster? i.e. if the first 2 doses had reduced efficacy as far as breakthrough infections after 6 months, what level of improvement does the Pfizer booster offer? Again, it's still very early days. I'm relying very much on the Israeli experience, plus some limited small trials conducted by Pfizer. But very clearly, booster doses dramatically increase antibody levels. And for the brief period of initial follow-up, because again, Israel only started doing it in June or July, I think the end of June for people over 60, and they've reported data just through the end of August, I believe. People who received a booster shot had a dramatic 5-fold reduction in infection compared to those who had not received a booster dose. And the link is to an initial New England Journal of Medicine report of some weeks ago, and there was an updated report published just yesterday in the New England Journal, which is publicly freely available to those who are interested in reading more. And Pfizer booster, should we still mask and distance when around vaccinated or unvaccinated people indoors? Or are we fully protected against a breakthrough case so long as a new variant hasn't emerged? Again, still early days, don't have enough information to warrant changing recommendations. So at this time, CDC and state recommendations remain the same. It's recommended that people mask indoors in public settings and distance as much as possible. Next slide, please. And then I think this might be the last question, but it's about the increasing risk of dying from COVID-19 corresponding with age. And yes, age has been the greatest risk factor for severe COVID disease and death throughout the pandemic. The risk is many-fold higher in the oldest people compared to young adults. And it's not limited to COVID, of course. Age increases the risk of severe disease and death for many medical conditions. And, while age is an independent risk factor, it's also associated with, as we get older, we're more likely to have other medical conditions, diabetes, high blood pressure, heart conditions, et cetera, which will also increase our risk. And, the concepts here is that, all parts of our bodies senesce or age, and our immune systems age also. That being said, immune function in older people varies a lot more than it does earlier in life. Some older people have extremely functional, well-functioning immune systems, whereas other people are much more vulnerable, and it's difficult to know who's in which category, and so these recommendations based on age apply to everyone. And we do know that on average immune responses to vaccinations are reduced in older people compared to younger ones. That's been known to be true of influenza for a long time. Those are the people, the older people are the ones we're most interested in protecting, but unfortunately older people don't respond as well to influenza vaccination as younger people either. And that's the reason that there are now several different higher dose or adjuvenated or booster influenza doses available and approved for older people. Next slide, please. So our CDPH vaccine action plan basically outlines how the state will begin administering booster doses to eligible Californians. We will continue to keep equity at the center of our efforts. There's been significant disparities in both the effects of COVID and access to testing and vaccination, between wealthier and more impoverished, more disadvantaged communities in California, and we're trying to keep those gaps as small as possible. And want to emphasize that our highest priority, higher than booster doses, is still to keep trying to get more unvaccinated people to get their primary, their initial vaccination. There's more disease to be prevented, more lives to be saved by doing that than with boosters right now. But we want to do that while still being able to administer booster shots to people who are eligible and interested. And at the same time, we expect that the federal authorities are likely to make children between 5 and 11 years old eligible for Pfizer vaccine, probably before the end of this month or in early November. Can't truly predict what the advisory committees will say, but there's a FDA advisory committee scheduled for, I think, October 26th to consider vaccinations for kids between 5 and 11. Next slide, please. And that's all I had. And again, happy to take additional questions and do my best to answer them.
Yeah, thank you, Dr. Boop. I really appreciate that information. And I think just the overview and that level of information about booster shots has been very helpful. Appreciate you being able to address the questions that we sent to you previously as part of your presentation. I think that definitely it was really helpful. I think because we sent those questions to you earlier, we don't have any questions in the question box. So I'm going to take that as a good sign that the questions that were out there have been answered by you today. So really appreciate that. We'll give it a few more minutes, see if any questions come in. But we do know that, you will have, you won't be able to stay for the entire webinar this afternoon. But just want to say thank you again for your time and for the really great overview on coverage of booster shots.
You're most welcome, Jill. Thanks for the opportunity. And I'm going to turn off my camera now, but I'll hang around in case there are questions, until closer to 3.
Okay, thanks so much. All right, everybody. Well, we'll proceed with the remainder of the presentation today. I'm going to take us through a little bit of some updates on CDA, the department, and CVAS, some program updates there. So Lynn, if you could, next slide, please. So when we last met, we let everybody know that CDA was moving. So in fact, we have moved. We have moved into our new location in Sacramento at Gateway Oaks Drive. So just want to make sure everyone takes note of that. All correspondence should be directed to this new address. Of course, our email addresses and phone numbers will all remain the same. Nothing has changed with those, but just please take note of our new location. And I believe we've pretty much updated our correspondence to include our new address on documents and such. So you should be seeing that coming on any correspondence that you receive from us at this point. Next slide. Wanted to draw everyone's attention to changes that recently occurred with its CDA. Some exciting news to share. Kimberly McCoy Wade, who's been the Department of Aging's director since 2019, recently was appointed by Governor Newsom as a senior advisor on aging, disability, and Alzheimer's. So she will be moving on to this new position effective on Monday, and we will definitely will be sad to see her go, and much appreciative of all the support and effort that she has devoted to her time at the department. But we know that she's not going far, and that we'll have a great advocate in the office, in the governor's office. But with that, we have a new director has been appointed for the Department of Aging, and that is Susan DeMorris. And Susan is certainly no stranger to the field of aging, and she is really a well-known supporter and advocate for aging issues. She will currently holds the position of Director of Public Policy and Advocacy for the Alzheimer's Association. Susan will be joining the department at the beginning of November. So we again look forward to Susan joining the department, and know we'll be in good hands. Next slide, please. Just want a reminder today regarding our monthly statistical summary report, data verification. As you know, the MSS reports, all providers submit their monthly MSSR data. And some of you may have received a call or an email from CDA. We had been experiencing some issues with the submission of the data, and what's been happening, and there's been kind of been a recent change to the PEACH database, which just moved the fields, the Medi-Cal fee-for-service fields and Medi-Cal managed care fields. I think has created a little bit of confusion, and so we want to draw your attention to that today. Please, when you're submitting your data, please pay attention to the order of the payer types on your screen and enter your data accordingly. And this is really in particular applies to boxes 4 and 5, the number of participants served and the number of participant days. So like I said, many providers are inadvertently entering attendance data in the wrong field. They may be, they're entering Medi-Cal fee-for-service numbers, Medi-Cal managed care, and vice versa. So I'm just want to bring up a screenshot on the next slide to kind of give you an illustration of what I mean. Next slide, please. So what you're seeing on your screen here is just, again, a screenshot of the MSSR when you're inputting in PEACH. And you can see in particular the first arrow in box 4, you'll see it used to be Medi-Cal managed care. That box, that field was on the top, and Medi-Cal fee-for-service was below it. They've been, with updates to the PEACH database recently, that order has changed. So please just pay attention when you're entering your data there to make sure that the correct numbers go in the correct box. Okay. And just another update too, we are at CDA working to get back to conducting on-site center surveys. As you all know, we've been doing telesurveys since March of 2020, and we're looking forward to getting back out in the field and seeing all of you at your centers. But for the time being, we're going to continue with telesurveys, likely up through the end of December. We are planning on resuming on-site center recertification surveys as of January 1st. That is the plan for now. There may be some exceptions to this. We may be conducting on-site center visits before then, perhaps as a follow-up to a center's plan of correction or other compliance determination reasons. So we do expect we may be conducting some before January, but for the most part, on-site center recertification surveys will resume in January. Okay. Another reminder, just bring your attention today, many of you all should be receiving a weekly survey that we have been distributing to all of you, and this is the disaster impact survey. Many of you may recall that this is something that we had sent out last year as well. We are again required to report any impacts of that local disasters may be having on your center operations, on your participants. And so in order to gather that information, so we're aware of those impacts, we send out the Survey Monkey on a weekly basis. So again, it's just to identify those centers whose operations are currently impacted by fire, drought, or another disaster. If you're not currently experiencing any impacts as a result of a disaster, right, fire or drought, you don't need to respond the survey, but we just ask if you are, please send in your response. Okay. And those will probably continue for the time being. Okay, this next slide, just wanted to draw your attention as a reminder. We know we have, can be some turnover at centers, new staff coming on board, and just wanted to make, and for those maybe who've been around for a while, just want to draw your attention and provide as a reminder that on our CBAS, CDA CBAS webpage, we have under the toolkit tab, see the toolkit tab is outlined there in yellow, highlighted. Under the toolkit tab, we have several different tools that have been provided as resources for providers. And I wanted to draw your attention to the center assessment tools today that you'll see there that are listed. We have several center assessment tools that were developed to assist providers in doing your own assessment of compliance with the requirements pertaining to particular areas. So again, we have tools pertaining to activity programming, medication storage and administration, the social services, training requirements, etc. So these are there for your use, just as a tool for you to use, again, to help you just do a self-assessment and help you determine, again, if you're meeting the program requirements in that particular area. There's a couple other resources that are listed on that page as well. You see under assessment screening tools tab, and those are also available too. We are currently working on some updates to update the links for those documents under that particular link, and hopefully we'll be getting to those shortly. But just want to make you aware of this page, and especially for new staff who are coming on board. These are some good tools to help them, again, understand their job and responsibilities. Next slide, please. Okay. So I think we are up to, public health orders. These are just some reminders. I believe probably all of you are very well aware of the public health orders from July 26th and August 5th, which outlined the testing requirements for healthcare workers and verification of worker vaccine status, and also the requirement that the healthcare workers must be vaccinated. So we have some links to those, the all facility letter that talks about those requirements, and also all center letter that does as well. So just wanted to put this on the screen today, just to remind everybody of those. And we've been working with the Department of Public Health. The other week we had a webinar in which they addressed these particular public health orders, and were able to answer some questions regarding those. And my apologies, we are working on getting that webinar posted. Been experiencing some delay, I think in part because of the move and just capacity here at the department. So that should be coming shortly, that recording for that webinar. All right. The other guidance, just want to bring a reminder again today. It was about the state testing program and supplies that are available. The California COVID-19 Testing Task Force is available to providers to train regarding antigen and PCR testing and provide the materials and supplies. This is, again, we know they have been experiencing a backlog after they really had been doing a lot of promotion and that. Not sure of the status now, kind of where that stands, but I know they have been available to providers to provide those materials and the training for the testing, if providers were interested in taking advantage of that. And again, there's no cost to providers or persons tested through this program. So the contact information for that program is there on your screen if you're interested in getting more information about it. Again, this was one resource that would help providers comply with the July 26th and August 5th state public health officer orders. So with that, I think that is pretty takes me up through my summary today, and wanted to talk with all of you. Can get into the topic of the day too, which is transition to congregate in-center services. And I've asked Denise to join us today to lead us through the discussion on that and be able to, and we'll have some time for question and answer at the end of the presentation to talk about that. So Denise, I'll let you
Yeah.
take it.
Yes, hello everyone. And Jill, let me just point out that we have questions both in the chat and the Q&A. And I know Dr. Boo has some time constraints today, so there are some things that may be for him before he steps off. You want to take a look at that? And Dr. Boo, if you're still there.
Yeah, hi. I was starting to type a reply to the question about taking NSAIDs, but I'm happy to answer this way. It's considered best practice not to take anti-inflammatories preventively before the vaccine. There are theoretical concerns that they may somehow diminish the immune response to the vaccine, but there's, if somebody's having flu-like symptoms as a reaction to the vaccine, feeling lousy, headache, muscle aches, it's fine. Take Tylenol, take your favorite anti-inflammatory drug to feel better. The effects on your immune response would, I'm sure, be minimal, if any.
Thanks, Dr. Boo. And Dr. Boo, we have another question came in, and I don't know if you can answer this or not. And because this, I think, really pertains to the public health orders. I don't know, do we still need to collect weekly COVID-19 testing results from staff who are exempt from vaccination? Can you speak to that?
No, I think that is the case, and I'm not an expert on the nuances of the orders, but certainly, like in the hospital clinic setting where I work, that is the case, and I think the same order would apply to many of the organizations on this call. So the mandate to get a vaccine, but if there's a reason why somebody can't get the vaccine, then they are expected to test weekly. Yes.
Thanks, Dr. Boo. And I should let everyone know too, there may be some more questions related to the public health orders that you have today. I'll just put it out there right now that certainly if those come in, we would probably need to defer those to the Department of Public Health to answer, since we are not the experts on that. So if you do post a question, just know that would be something that we'd have to refer on to our partners over at Public Health. So. All right. Dr. Boo, I think you answered this in the chat question, but I don't know if everyone saw it, so I'm going to ask it and just ask you to respond to it out loud here today. Do we anticipate that boosters will be mandatory for healthcare workers?
Yeah, so the discussions that I've been a part of around that, I'm not a policy or decision maker in the department by any means. But also the word from CDC is that people who've gotten their primary series, their 2 doses of an mRNA vaccine or currently a single dose of J&J are considered fully vaccinated and meet the expectations of the mandates. The primary series, the mRNA vaccines, they really are working great. I mean, there are more breakthrough infections, infections after vaccination, but the protection against severe disease, hospitalization, and death is very impressive and sustained. It's about in the 90% range, maybe somewhat lower in the elderly. And I think as long as we're not seeing like a lot of outbreaks in healthcare settings and whatnot, I don't think there'll be any changes. But again, this is all very new. I mean, the boosters are such a new thing. We just have to see what happens over time. But at this time, there's no talk of mandating boosters. Long answer, sorry.
No, that's fine. Great, thank you. And I think you might have in parts you were speaking to this before, but a question came in, for those who are infected by COVID, are they required to be vaccinated? And this gets at the issue of vaccination for, if you've already had it. Can you talk about that a little bit?
Yes, they are currently required to be vaccinated. I refer to it as being a hot topic of discussion. And I know CDPH. I mean, I just heard our state epidemiologist tell a group of county health officers this morning that she and others are pushing CDC to provide more guidance, sort of a scientific advisory on this issue, because some countries do accept evidence of previous infection in lieu of vaccine mandates or for entry to places where vaccination is required. I think New York may have taken the first step in the U.S. towards trying to accept evidence of infection for some purposes. I don't know the details of that, but right now, haven't been infected, you're still required to get, it doesn't count as a replacement for vaccination, but that could change in coming weeks or months.
Okay, thank you. All right, I'm just kind of scanning through the questions. One more question, I guess, for you, Dr. Boo, if you are able to answer this, just in generally, if you see or perceive if there have been any changes to safety protocols in light of Delta, just in terms of recommendations.
Well, nothing too recently, but you will recall that the nation and the state were basically saying you don't need to mask anymore, back in early June, and then as Delta surged and created great challenges, we first California and then CDC backpedaled and recommended masking in indoor places. So to that extent, yes, Delta has caused changes to safety protocols, but other than that, nothing that comes to mind.
Okay, thank you. Okay, I think one more question, and because I know you have to go, Dr. Booth, but do you know if it's possible to do antibody tests to identify the level of antibodies each person has before recommending the booster shots in the future?
Yeah, this is also somewhat controversial, but the official position on this is that we just don't know what the levels of antibodies are that confer protection, and there's a lot of different antibody tests out there, and you can't really they're not that well standardized, and the result of one may not really agree with another. And there's different types of antibodies. There's neutralizing antibodies that are directed against the receptor binding domain of the spike protein, and there's other spike protein antibodies, and then there's other antibodies to other parts of the virus. So the short answer is it's not currently recommended. It's an area of intense research. I mean, everybody very badly wants what's called a correlate of immunity, like some test that we can do that tells us whether somebody is protected or not. But right now, we don't have it.
Okay. All right. Oh, I think that Dr. Wu, I know you have to get going, and don't want to keep you any longer. And I know some other commitments today, but I want to thank you for being on the call with us and for all the wonderful information. We appreciate your time.
Take care, everyone. Bye-bye.
Thanks, bye. Okay, and just a quick note to everyone, I just, before Denise continues, I did, please submit your questions through the question and answer box. I did disable the chat box just so we could have kind of one way in for the questions coming in, so we can track them a little bit easier for you all today. So thanks. Go ahead, Denise.
All right, thanks, Jill. Yeah, that was distracting my attention. I couldn't pay attention to both spots at once. So, hi, everybody. Good afternoon. Thanks for being here. Happy to share this afternoon with you and to follow Dr. Boo in a very informative presentation. So we're going to start today this part of the program with sort of a recap. We could get the next slide up there. So, pretty much we just want to focus on where we are today, how we got here, and where we think we're heading. But I do say that with a qualified where we think, as Dr. Booth said in one of his answers that he typed, I liked it, that we're still learning, and the only constant in this pandemic response seems to be change. So I definitely appreciate that. We've all been flexible, you providers, managed care plans, so we appreciate that for sure. And that continues to be sort of where we are with needing to be prepared and to remain nimble for what comes at us next. So with that in mind, we'll proceed with a little bit of a recap. So with All Center Letter 2104, which we sent out in April of this year, we set this phased transition in motion, phased transition back to congregate services, to get all the participants back into the center. And we had previously stated that we wanted everybody back in by October 31st, again, giving a window of time that this could happen in a safe and orderly way. That's how we have been phrasing this phased transition all along. So that was 2104, and much of that policy is still in place, and we'll touch on that in a little bit. And then All Center Letter 2110, which we got out to you at the very end of August this year, we postponed until further notice the October 31st deadline for at least 1 day per week for all participants. So we postponed that deadline, but we did not stop the transition to in-center services. So there has been a little bit of still of that message floating around that we stopped that transition, and that is not at all true. And we hope to emphasize that here this afternoon. So some of the key points there on your slide. That deadline for all participants to return was the only change to the phase transition at this point. So we want to emphasize that. So we recognize that with the many things that needed to be taken into account, the new public health orders for vaccination of staff and tracking that information, the continued efforts to get participants vaccinated, the Delta variant's arrival and sort of disruption of the path that we were on. And then now with the boosters, we recognize that there was a need for a little bit of a pause in that deadline, but continued to emphasize that with no end date for this public health emergency and the CBAS task flexibilities in mind as yet, that we want to make sure that we continue to anticipate the eventual end of the public health emergency and get everyone sort of prepared for that in-center services return and the orderly wind down of all of the flexibilities that have been in place for tasks. So that's what happened with both of those all center letters. And this still brings us to today, 2110, where we are with that unknown date for the public health emergency end and the postponement of the deadline for services in center back to at least 1 day per week per participant. So that's sort of the state of the state right now. If we can get the next slide, I think we're going to continue on with some more recaps. Also in 2104, we specified sort of some new expectations regarding this return to congregate. And that included getting our full multidisciplinary teams back in place, getting assessments and evaluations done for everyone, and that on a staggered basis beginning in July 1. We'll talk about that a little bit more here in a minute. And IPCs updated to reflect the in-center services and whatever continuing remote services that were necessary. So that all began with All Center Letter 2104. But we recognize, again, that we want to emphasize that, that getting back to business in centers, because that's what this service is primarily about, essentially about. And so we want to make sure we're continuing to move in that direction. Next slide. So again, thinking about this this transition to congregate services and what we all want to be focusing on right now, participant vaccinations and boosters is still forefront to get to maximize our safety and reduce our risks for in-center services. So that's an obvious focus. And then supporting and preparing participants for their safe and full return to congregate in-center services. And that can mean an awful lot of things, including preparing those who have decompensated at this time to gain strength and stamina and flexibility to get back to an in-center schedule, et cetera. So our focus continues to be how do we do that? How do we help providers on that path as well? So to the right of the slide there, the right column, we're also saying a focus should be on doing what we're calling the utilization math for your center. So that data that Jill talked about moments ago on your MSSR, your monthly statistical reports that you give to CDA with a breakdown of the number of people that you're serving daily, the number of participants you have, et cetera. There's a lot of things that you need to be considering. Some of you a lot more than others. So we actually, there's a link down at the bottom of this slide to our newsletter that just went out yesterday, our CBAS updates, that has an article about this and some more detail. But essentially, it boils down to this. These things need to be considered. Will any of your participants be unable or unwilling to receive services in center in the coming months? Knowing who those folks are, if they are at your center, and sort of being ready to adapt when we get back to full in-center services. Which of any of the participants will need changes to their authorized days as they return to in-center services? So some individuals who perhaps have been getting 5 days a week now, who will not be able to return that amount for a variety of reasons after we return to in-center services. Which of your participants are in that category? Which of your participants have you only been able to serve at this time 1 or 2 days, who will need an increase in days once you get back into center, or will be wanting an increase in days, families going back to work, all sorts of changing circumstances there. So knowing who these participants are, and again, I know this is sort of rudimentary, but these are things that at CDA we're talking about internally, and we're talking to many of you about this sort of utilization math. So we want to make sure we're priming all of you to be thinking about that. And our managed care plan partners, who we've been talking with throughout this time, they're paying attention to this as well. There are implications for everyone here. And then if your center is currently serving above your license capacity daily, well, what's your plan for when the task flexibilities end and there's no longer the remote services as we now know them? So these are all things that need to be considered at each of your centers. And again, CDA, with the advantage of having all of the aggregate data for the entire state, we can look down from A to Z with all of our centers and see where we think that there are potential special challenges that some providers will have, because it's going to be complex enough getting back to in-center services. What we've seen and today, including notes coming in regarding challenges with recruiting and hiring and retaining staff, and all of those complexities with getting back to operations in center. that's enough of a load. We need to be thinking now about what's happening with the numbers at your center and what are all those implications. So next slide, please. We'll take a look at just a little example of this. So we put together this. This is from your June data, which is reported in July. Usually takes us a little while to scrub all that and make sure we've got everybody's information in. And so it seems like it's a little late, but it's actually nice clean data from this summer. So what we found in that MSSR data, and again, there's a link to this on our website down below. You can look at the entire state, what's happening there. And we have 41 providers who currently serve above 125% of their licensed capacity daily. So these are the centers that we are talking to. We have a number of other ones that are serving, let's just say licensed capacity is 100 and they're serving 101, 102. Not a big concern. When we get back to in-center, we know there'll be changes and people won't be able to attend on certain days, et cetera. But right now, those 41 providers who are serving 125% of their licensed capacity daily have some work to do with figuring out how that's all going to work. We have 18 providers who currently serve above 150% daily. So again, just to remember how during regular times, pre-COVID times, we have a report on all of your MSSR data that looks like your license capacity is 100, your average daily attendance or your utilization, it is, let's just say 90. That's usually what we see is people functioning, providers functioning below their license capacity, because it's pretty hard to stay right at your license capacity and not go over and have a real serious problem with too many people in the center on any given day. So generally speaking, providers functionally operate about 10% less than their license capacity. So if you're now at basically 125% or 150%, or perhaps for a few of you, even more, there are going to be some real challenges finding a seat for everybody at the end of this process. So again, this is all sort of basic stuff, but just to illustrate the things that we're thinking about, because the time for planning and action is now, and we don't want anybody caught by surprise with this. Including our managed care plan partners who have to work with all of you on this issue with authorizations and days of service. And just the reminder that there are real people and real families on the end of this issue, and we want to make sure we take care of them appropriately. So when CVAS ends, centers that need to operate under their license capacity, at or usually under their license capacity. And some participants won't be coming back or won't be going to the center, even some of them for the first time, and may need reductions in authorized days. So having a plan for your center, having the steps sort of laid out. For example, what changes are you making now with regards to your assessments and your IPCs and your team processes, talking about this? Are you communicating with your participants and caregivers and your managed care plan partners as you evaluate changes in need and changes in your operational capacities? So you just want to illustrate that, again, engage you in thinking about it, all of you, and also let you know that if CDA doesn't reach out to you and you're in this category, we want you to reach out to us and talk to us about how you might work through some of these steps, and definitely to coordinate with your managed care plan partners. So all very important preparation steps. All right, next slide, please. Again, more on what we should be focusing on now. This is our at CDA, our focus as well, that for the remainder of the time that these flexibilities under CVAS tasks remain in place, we want to make sure that any continuing remote services especially meet those task requirements. I think we feel fairly confident that the in-center services are things that you're all quite familiar with, but that the remote services continue to focus where they need to be focused as we get back to our pre-COVID program times. But the remote services, again, these are all things that have previously been stated in all center letters. They need to be person-centered, goal-oriented, related to the needs of the individuals that you're serving, whether those are health, psychosocial, therapeutic, and that your health records have needs stated clearly in your IPCs or documented as emerging needs is somewhere in the record, progress notes. These are all sort of audit trail things or clear trails of what's happening with your services at your center. Again, this applies to all services, but again, making sure that as we provide remote services as they continue to be needed, that we meet all of these criteria. The recommendation, the documentation in the health record needs to include those services and supports and very specifically and how they're provided and their outcomes, who they're provided by. So multidisciplinary team members within their scope of practice, trained members of the center staff, such as program aides, overseen by the program director and working in collaboration with those MDT members. So next slide. Again, that's all pretty much review. These documentation requirements really represent a sort of a some CBAS and ADHD basics that have always been in place, and then some of the new things that were established in also Center Letter 2104 regarding the changing expectations for the IPC as we transitioned back. Those requirements, we want to make sure everybody knows that they continue to apply. Next slide. That July 1 date that was set with that All Center Letter 2104 for the beginning of our transition to congregate services, that it started back then, and that we specified some things about those IPCs that were initiated then. The beginning of the pandemic, we had a lot of flexibility in the IPCs and care plans because, well, we were scrambling to do all sorts of things at the beginning, and as we were getting a little bit more familiar with things and beginning the transition to congregate, we clarified a number of things, including that the IPCs needed to have the plans for the participants' return to congregate and center services, that they needed to address the participants' present or anticipated need for in-center service. So if they weren't ready to come back right now, that needed to be in the IPC. And then any continuation of remote services needed to be addressed there. They need to be completed in total, including care plans in boxes 13 and 14. So for a while, we had a lot of flexibility around how to narrate in a narrative way describes those remote services in boxes 13 and 14. But with All Center 2104, we specified that we wanted you to get back into boxes 13 and 14 and address both those in-center and remote services that you were scheduling during that authorization period. This was a little challenging and still is because sometimes that schedule is fluctuating. But we did ask that be identified. And now, of course, we're sort of tagging on to this that IPC focuses, the focus should be on interventions that support and prepare the participant for their full return to congregate services. And then again, boxes 15 and 16, we go back to sort of just any additional information that supports authorization of the services. So if clarification of remote services needs to go in there, that's fine. But the expectations are that we're getting back into 13 and 14 boxes and being very specific about what are the needs, what are the interventions, and what are the goals, person-centered, and how they reflect medical necessity. So again, a lot of that is review. With the layer on there of now, as we're getting deeper into this transition, that we need to be really focusing on how we're preparing and supporting participants in their return to congregate. So, so some repetition here for sure, but want to make sure that everybody is on board with that. So next slide, please. And a little more in the way of some repetition, the documentation in the health records Again, it needs to demonstrate that services provided address assessed or identified needs. And again, some of this, the emphasis here is as our managed care plan partners and CDA get back to more of our traditional ways of oversight, even though some of the on-site surveys have not yet begun. This is where we are all headed, as Jill said earlier. We've been talking a lot with our managed care plan partners. They've got a lot on their minds as to how they're going to be implementing new CalAIM requirements and how they're preparing for this transition to full congregate services at this future date. So these are all important that as we think about you getting more organized, providers and ready for in-center, and us getting more organized with our oversight functions. We want to see health records that demonstrate things like the changes to participant care plans that take place between when you get an IPC authorized. You get it authorized for 6 months, and then there are changes in between. That's always been the case, but we want to make sure that those are getting captured in the record, those changing conditions and emerging needs. That you have your notes regarding your services provided. Sometimes we call these daily notes, narrative notes, flow sheets. They all go by different names. They're the same thing. When you deliver service, the specific service is noted, and that the name of the staff member who provides the service and the date that they're provided all belong in those notes, and the outcome of the service, meaning the impact or result or effect that the intervention had on the participant. All that needs to be a clear trail in the records. So next slide. So before I hand it off or back to Jill or take a look at any of the incoming questions, which we hope you have some, that in summary, when the federal public health emergency and our CBAS task flexibilities is going to end, that is not yet known, but we began this transition to in-center congregate back in April, and we continue on, again, as Dr. Boo said, remaining mindful of the fact that the only constant here is change, but we need to be prepared and flexible, nimble on our feet here. So our focus now is with all of you on ensuring that for the remainder of the time that these task flexibilities are in place, we continue to address our participants' most urgent needs, and that we're constantly planning and preparing for that full return to the center services that we know and love. So that's it. I thank you for indulging a little bit of a review here, and we've been saying this for some time, but we look forward to the continuing effort, and thank all of our partners. We've spent a good deal of time talking recently with our managed care plan partners and vision team partners about remote services and how they need to look in this time. And we appreciate that partnership, and a lot of wisdom gets distilled from all of those folks, and we hope that we're constantly sharing that with all of you as we move toward what we hope is going to be the resumption of CBAS in the pre COVID and pre-pandemic era. So that's it for me, Jill, and I guess we can start looking through some of these questions, unless you wanted to continue on with the rest of the slide, Jill.
No, well, we can. I think it's a good time to pause here and take some questions that come in. I think we have a few that are somewhat related, and I think are pretty important to address, and that has to do with the continuation of tasks, the continuation of remote services as a CBAS, I guess, modality, way of service. So one question, is there a plan for hybrid program after the task is over? And again, talking other question about, the hybrid model. And I think what we do want to make sure that we're clear on is that CBAS tasks will end. Right now, the question is when. Remote services are going to be ending. Any future provision of remote services through CBAS would be something that needs to be approved and changes made to the 1115 waiver that we currently operate. So the special terms and conditions that CBAS currently operates under through federal authority, through CMS, those would have to be modified in order for us to continue or to provide remote services in some fashion within the CBAS program. The 1115 waiver is up for renewal. The state has applied, has requested some changes to the special terms and conditions of the waiver to allow for the provision of remote services in certain conditions, in limited conditions, I guess, and the limited conditions being in times of public health emergency or a state or federally declared emergency, or in the instance of particular participant emergency or crises. And again, these would be kind of short-term, limited, time-limited events. So there is no guarantee that the CMS will approve that, but again, the state and Department of Health Care Services, and we're working in partnership with them to communicating with CMS about the possibility of including that in the 1115 waiver renewal this upcoming year. But before that happens, we likely, CBAS remote services as we are currently operating will be ending. We just don't have a particular date yet. Denise, anything you want to add to that? Maybe I missed?
Well, I think it relates to this, and it's another question that has come in where we have been talking about the task flexibilities ending on a date yet unknown. So they're saying, does this mean that that task will not end on January 1, as previously said before? Please clarify. So the things that we know at this point with regards to the public health emergency, there's the federal public health emergency that CMS has granted authority for the state to operate these CBAS task flexibilities. This is on the Medi-Cal side of the house, the requirements. So those requirements under tasks that have been authorized, those flexibilities have a date, I think, of the end of the year, Jill. I'm not sure, it might even be sooner than that. But the expectation earlier on was stated that these flexibilities would have if in fact that the public health emergency ends on that date, and it has been extended for the last, however, 19 months now. And so if it weren't to get extended, that the expectation would be in order to for the states to unwind these programs, to ramp them down in a way that's safe and orderly for everyone, that there would be a 6-month wind down period allowed. So again, none of these decisions have been made at this point as to when the end would be of the public health emergency. That has not been declared, and then whether we would use some or all of that 6-month wind down authority. It's probably, I hope, not confusing, but again, that's on the subject of the public health emergency flexibilities, which is a different subject from what Jill was responding to earlier with regards to the 1115 waiver provisions that may be authorized beginning in January. Two different paths. There's also another question here, Jill, of hello, is there an end date for the center days and center service hours, partial week attendance, less than 4 hours attendance? And that's all in that same category of the state's ability to ramp down or unwind some of the flexibilities that are in place. And again, how do we do that in a way so that we don't create problems for participants and families, for starters, where we have a discontinuation of their services or disruption, and so that'll all be part of what we consider as we look at when we get a date definitive. How do we pull back some of these flexibilities in a way that allows all of you providers to ramp back operations so that you can meet people's needs, and allows time for this all to take place.
Okay. I think we had another question that came in about participation agreements and discharge plans. and what are the requirements during tasks. So at this point during tasks, participation agreements and then discharge plans, the provider should be completing those as is typically required through regular CVAS. You should have a participation agreement and should be updating those regularly regularly, I guess, as requirements dictate, as well as discharge plans. You should have be following the regular requirements for having a discharge plan on file and updating them as needed for each participant. Just taking a look at these. Someone was asking about any changes to the in-center assessments for IPCs, and will there be any guidance provided regarding services provided when a participant is hospitalized?
So I'm not sure I understand the question, but we did talk about the requirements for the multidisciplinary team assessments in the All Center Letter 2104, where we specified what needed to happen for the July 1 and forward IPCs. And as far as hospitalizations, I guess, as we think about getting back to our original requirements in law, regulations, and the waiver under CBAS, there are specific regulations that address what happens when a participant has a change in status, and when someone is ill or injured and getting a physician's authorization for their return to the center under certain circumstances. So we would be returning to all of those requirements as we get back in center. So I'm not sure if that answers the question, Jill, or.
Yeah, and I don't know if we're going in the direction, if we can speak to, can centers bill for services when a participant is hospitalized? So I think we also need to consider that would be duplication of trying to think of any instance where that wouldn't be, but for the moment, if a participant is hospitalized, then since they were receiving their services, so that would be a duplication, and no, that would not be a billable service. If you're providing, or in some fashion provide, well, the participant is hospitalized if you're providing some sort of service.
So, and I think that clarification there, then, if that is the question, would be if they're admitted to the hospital, as opposed to someone you had provided services to earlier in the day, they have a 911 call and go to the emergency room, that would not be considered a duplication, but an admission to the hospital and a continued provision of services on other days would certainly be.
Yeah, thank you. Yeah. Looks like there's a couple questions pertaining to some public health guidance regarding social distancing requirements inside of program buses and vans. And again, I would recommend that you refer to the recent all facility letter that was issued by Department of Public Health on September 17th that spoke to some vaccination status and distancing and their recommendations around that. So that does speak to those questions and the distinction between vaccinated and unvaccinated participants. I would say for the most part that public health guidance that came out in the all facility letter does allow for or does indicate that for if you have a group of fully vaccinated participants, the distancing requirements, the 6-foot distancing requirements do not apply. But again, that's for for a group of fully vaccinated participants. But again, please look over the all facility letter that was issued by Department of Public Health for more information. And I think there's a few other questions on here, Denise, that I don't know if we can get into today because those are maybe a longer discussion around ensuring equal access with unvaccinated participants, and certainly I know questions that many of you are wrestling with right now.
Yeah, I also would say there's someone who's asking about centers that are operating over capacity, as we shared in that little MSSR example, and serving more participants going forward. I'd say reach out to your CDA analysts and have a conversation with them about this issue and some of the many implications and pathways there.
All right, I think that takes us to, it's 3:30 already. Certainly went fast, so that is time, and our webinar was scheduled till 3:30 today. So if we didn't address one of your questions today, please send it. You can, we'll have a contact information at the end of our slide deck here today. I know most of you probably know our CBAS email address. Please feel free to send your questions there, and we will do our best to address those. And if there's others, there's definitely some resource information here for all of you as part of the slide deck today. And thank you, Lynn. Those are our contact information there. Feel free to submit your questions to the inbox, and we'll get it to the appropriate person. All right. Well, everyone, once again, thank you for the good work that you all do in caring for and providing services for our participants around the state. We appreciate, as always, your questions and feedback and input, and enjoy working with all of you. Please, again, don't hesitate to reach out to us if you do have questions on anything, and happy to work with you. Thanks for joining us today. I'm so glad you could be here, and we will be getting this presentation webinar posted on our website as soon as we can. Thanks all of you for being here, and have a great evening. Bye-bye.
Bye-bye.